to our proffered abstracts. And the first of these abstracts is from Xinyu Wang on the comparison between the diagnostic performance of MRI black blood thrombus imaging and CT venography for detecting deep venous thrombosis.
Okay, thank you. Hello everyone, my name is Xinyu Wang and I'm from Beijing Chaoyang Hospital, Capital Medical University. And today I will introduce my work about comparison between the diagnostic performance of MR black blood thrombus imaging and CT venography for detecting deep vein thrombosis. Deep vein thrombosis is a common venous disease caused by the abnormal coagulation of the blood in the deep veins of the lower extremities. When spontaneous thrombolysis and subsequent thrombus migration into the pulmonary circulation, it can lead to potential life-threatening complication, pulmonary embolism. So early and accurate diagnosis of lower extremity DVT are crucial to prevent its severe PE. DSA has traditionally been the gold standard for the diagnosis of DVT. However, its technique's invasive nature has led to its rare use in the poorly diagnostic setting. In the real-world practice, CT venography is more commonly used to diagnostics of DVT, with reported sensitivity ranging from 71% to 100%. But they all have a radiation exposure concern. A novel, no-contrast divan-weighted MR black blood thrombosis imaging technique, DantiSpace, has an excellent performance in confirming and staging DVT. However, the consistency of the DantiSpace and the CTV for detecting DVT remains unknown. So the study aimed to compare the diagnostic performance of DantiSpace and CTV for DVT using a 3T MR system. A patient underwent the DantiSpace protocol on a 3T MR scanner and with a combination of two 8-channel body coils. 3 station scans were performed to cover the entire lower limbs, and the scan parameters were as follows. For the imaging analysis and measurement, the unilateral lower extremity veins were divided into 10 segments, and the presence of the thrombus were observed by 2 experienced radiologists. Thrombi were classified into 4 groups, including hyperintense, iso-intense, hyperintense, and mixed intense, by 2 radiologists based on the average signal intensity of the thrombus and adjacent muscles on the DantiSpace images, and the statistical analysis as follows. In total, 61 thrombus segments from 10 patients were observed, and based on the thrombus signal contrast, they were divided into 4 groups, and 4 segments showed hyperintense thrombus, 21 segments showed iso-intense thrombus, and 31 segments showed hyperintense thrombus, and 5 segments showed mixed intense thrombus. There are scientific difference in relevant signal intensity ratio among the different types of thrombi, except iso-intense group and mixed intense group. Using ICC analyze the excellent inter-observed agreement between the 2 radiologists. And also excellent agreement was noted between the DantiSpace and CTV in identifying thrombus. In AOC analyze, a higher AOC value was shown in DantiSpace than CTV, and a higher sensitivity, positive predict value, negative predict value, and accuracy was also shown in DantiSpace than CTV. As the figure shows, there are 3 cases of different signal and morphology of DVT, and we can see T1-weighted MR images can currently display the localization and different signal characteristics of the thrombi. This is an example of a 44-year-old male patient with left leg strain, swelling, and pain. He has a history of immobility and main symptom duration within 2 days. In CT images, the thrombi were difficult to identify and the boundary is not clear. However, in DanTspace images, inhomogeneous iso-intense thrombi and hyperintense thrombi inside the venous lumen can be clearly displayed. This is another case. 82-year-old female patient also has with left leg swelling and pain. And after CPR reconstruction, external iliac vein thrombosis can be clearly visualized, and the proximal segment of the thrombosis shows hyperintensity. Additionally, MRI can clearly display the eccentric Moore thrombi, which are challenging to distinguish on the CT images. Therefore, T1-weighted MRI can identify thrombi with different signal intensity and morphologies. So, DanTspace demonstrates a higher sensitivity, specificity, and accuracy for diagnosis of DVT at 3D MRI without the use of contrast agent, and it can effectively suppress the slow-flowing blood flow signal, clearly showing the thrombosis components and the morphology. Visualized thrombosis signal can be observed on DanTspace imaging, which may be due to the different contact of mesomeloglobin in the thrombus between the acute, subacute, and chronic phase, reflecting the stage of the thrombus. So, in conclusion, compared to CTV, DanTspace improved the diagnostic accuracy in detecting DVT, and T1-weighted MR may be used to differentiate acute thrombosis from subacute and chronic one, currently distinguish the stage of thrombi. That's all. Thanks for your attention.
Thank you very much. Time for a quick question. Anyone? Jeremy has a question and Manuela has a question.
Sorry.
Sorry about that. That's a lot better. Do you have any data that would allow you to make the link between the signal intensity you saw with the clots and then the treatment response, meaning like lytics to dissolve it versus just the need to break it up or remove it from a catheter or stent?
Yes, we will find some thrombosis with the higher hyperintense and the components just more like soft. This thrombosis might more easy to migrate into the pulmonary circulation. It's dangerous. Thank you.
And Manuela?
And to my knowledge, the group of Wisconsin years before, and our group confirmed this, the disease regarding DVT and pulmonary embolism is best diagnosed by contrast-enhanced MR. You give contrast intravenously, do the breath hold or not breath hold with a twist. You see the pulmonaries, and then go down and look at the venous system, and you see also teeny mini thrombi in the internal venous system and also in the lower legs below the knee. And these thrombi sometimes bigger than 8 millimeter, and they count regarding this disease. So I personally prefer the contrast-enhanced phlebography.
Okay, thank you.
Thank you very much.
Okay.
Any other questions? I have a quick question. Was below knee DVT better shown on the Dante sequence than CT? Because CT is very difficult below the knee with the smaller vessels. Is that where the MRI is better? Is that why it's looking better in your analysis?
Sorry, the last sentence?
Is your analysis saying that the MRI is better than
Yes.
CT? Is that because it's better below the knee?
Yes, the MR we can cover the entire limbs, and we needn't the contrast agent. But CTVs, it's necessary to inject the contrast agent in the leg. So MR, we think the MR is preferred to the CTV.
Thank you very much. So the next talk is given by Xinyu Tong and is titled Early Characterization of Renal Impairment in Patients with Systematic Sclerosis by Multiparametric Magnetic Resonance Quantitative Imaging.
Okay, hello everyone. My name is Xinyu Tong from Tsinghua University in Beijing, China. I'd like to present my work about the early characterization of renal impairment in patients with systemic sclerosis by multiparametric MRI. Systemic sclerosis, SSC, is one of the systemic autoimmune diseases which frequently leads to fibrosis of multiple organs. The involvement of kidney may lead to renal insufficiency or even scleroderma renal crisis, SRC. However, the renal involvement in SSC may remain unnoticed at subclinical stage until late in progression. The diagnosis of SRC depends on clinical characteristics. However, the invasive procedures may increase the risk of complications, and the microstructural and functional impairment may occur prior to clinical symptoms. So this study aims to characterize early impairment of renal microstructure in SSA patients using
I'm sorry, we are still seeing only your titles.
Sorry. Sorry, I will begin with the beginning. I'd like to present my work about early characterization of renal impairment in patients with systemic sclerosis by multiparametric MRI. This is one of the systematic autoimmune diseases which frequently leads to fibrosis of multiple organs. The involvement of kidney may lead to renal insufficiency or even scleroderma renal crisis, SRC, and the renal involvement in SSA may remain unnoticed at subclinical stage until late progression. begin with my second page. So the diagnosis of SRC depends on clinical characteristics. However, the invasive procedures may increase the risk of complications, and the microstructure and functional impairment may occur prior to clinical symptoms. So this study aims to characterize early impairment of renal microstructure in SSA patients using multiparametric MR quantitative imaging. So in this study, patients who were diagnosed with SSA and age and sex match healthy volunteers were recruited and underwent renal MR imaging. Demographic and clinical characteristics of recruited patients were collected. The estimate GFR was calculated by CKD-MPI equation using the value of serum creatinine, and the eGFR value greater than 90 was regarded as normal value. The renal MR imaging was performed on a 3T MR scanner. The imaging protocol includes GWI, BOLD, and SAMURAI proposed by our group in 2022. The SAMURAI sequence enables to acquire multi-delay arterial speed labeling and T1 map of the kidneys simultaneously with excellent reproducibility. For SAMURAI images, we calculate renal blood flow, RBF, arterial bolus, arrival time A-BET, and tissue bed T-BET of renal cortex. For DWI images, the renal volume and mean DC values were calculated, and for both, the mean T2 star value of renal cortex were recorded. In the statistical analysis, we compare the group differences between SSA patients and healthy volunteers, and we also compare the multi-group differences between diffuse continuous SSA patients, limited continuous SSA patients, and healthy volunteers. The logistic regression analysis were performed to investigate the association between the MR measurements of kidney and SSA before and after adjusting confounding factors. As for the results, 46 SSA patients and 22 healthy volunteers were recruited in this study. No significant difference were observed in demographic characteristics. Compared to the LC SSA patients, the DC SSA patients had significantly higher MRSS and higher prevalence of digital ulcers. As for the SSA patients, compared to the healthy volunteers, the patients were more likely to have significantly lower T2 star value in the left renal cortex, and longer T1 value, lower RBF, and shorter T-BET in both right and left renal cortex. And this difference was independent of demographic information. So as for the patients with normal eGFR compared to the healthy volunteers, they were also more likely to have significantly lower T2 star value in the left renal cortex and longer T1 value, lower RBF, and shorter T-BET in both right and left renal cortex. And after adjusting for demographics, the difference was still significant. And compared to the DCSSA patients and the LCA patients, the DCSSA patients had significantly lower RBF in both right and left renal cortex compared to the LCSSA patients after adjusting for demographics. But the significance of the difference was attenuated after further adjusting for modified skin score and digital ulcers, and no significant differences were found in other quantitative measurements. And here we give an example for comparison of imaging characteristics between patients and healthy volunteers. We can find that in the up three lines, the patients were more likely to have significantly lower T2 star value, longer T1 value, and lower BF and shorter T-BET. According to the previous pathological studies, there might be some proper association between imaging measurements and renal pathology. For example, the increase of T1 value may be associated with interstitial fibrosis or inflammation, while the decrease of RBF and T2 star may be related to intimal thickening and episodic vasopathy. Notably, owning Tibet instead of ABET appeared a significant decrease, which may imply the impairment of renal microcirculation. So in conclusion, multiparametric MR quantitative imaging might be a more sensitive modality in characterizing early impairment of renal microstructure prior to global renal dysfunction and the differentiated subtypes of SSA patients. However, there are still some limitations in our studies. Firstly, this is a cross-sectional study with a relatively small sample size. Thirdly, this study did not compare eGFR value between the SSA patients and the healthy volunteers due to the lack of serum creatinine data from the healthy volunteers. Finally, the MR imaging findings lack histological validation. So in the future, we'll build a larger cohort and have long-term follow-up for patients, and we will verify the accuracy of perfusion parameters using PET-CT imaging. And in addition, we will perform renal biopsies in SRC patients to validate the imaging features by histology. Thanks all the colleagues related to this work, and if you have any questions or comments, please contact me. That's all for my work, and thank you.
Well done. You managed the interruptions to your talk very well. Are there any questions from the floor? I have my first question is, why do you think your T2 star values were low in the left kidney but not the right? That doesn't make any real sense to me.
Oh, okay.
Surely it should be both kidneys, not one kidney or the other.
Okay, thank you for your question. And we did the comparison between both sides of the kidneys, and we find the T2 stars only appear significant difference in only one side. And in the previous studies, we found that both sides of the kidneys, they are different in perfusion because of the different location of the organs. For example, the the position of liver and the spleen makes the blood different, and maybe the hemodynamic will be different into both sides. So we found that the perfusion between the two sides are different, and although the other side perfusion is not significantly different, but the p-value is close to 0.5. So we think the T2 star value is also the significant characteristics for the SSA patients.
Okay. Do you have data on single kidney GFR? Do you know what the GFR was for each kidney, or you only know the overall GFR?
Okay, thank you. We compare the eGFR only in the patients because we lack the blood sample for the healthy volunteers. So we just take the hypothesis that the healthy volunteers have the normal eGFR value which is greater than the 90. So this is also our limitations for these studies, and in the future we will did the eGFR test for our healthy volunteers in the future and make comparison between them.
Thank you very much. I think we should move on. The next talk will be given by Daniel Giese and is about clinical evaluation of a fast, large field of view, high resolution, compressed sensing, accelerated abdominothoracic native MRI technique.
Okay, thank you for reading out this title for me. I'm a full-time employee of Siemens. So we've heard in the last few days what the advantages of a non-contrast MR angiography are, including obviously the non-need of a contrast agent, which saves money but also saves workflow complications. It's a much simpler workflow if we can just acquire in the steady state. We haven't heard much about the advantage of being able to manipulate the contrast as compared to the contrast-enhanced MRA. And also, because we're not tied to the timing of the bolus, we really can scan with a high resolution and also with a high field of view. This comes obviously with the limitations, which is the long scan times potentially, the limited SNR if we compare it to the full contrast, the fat signal that we need to deal with, and also if we don't do it in a single breath hold, the breathing motion. So the goal of this work was to develop and evaluate the clinically native MRA with the features you can see here. So obviously it needs to be ECG synchronized. We planned to have an entire thorax field of view with a good temporal spatial resolution, feasible scan times. We need to compensate for breathing, and we need robust fat suppression. And also importantly, the scan needs to be feasible on 1.5 and 3 Tesla. The sequence was tested on 1.5 and 3 Tesla and consists of typical ingredients we know since a very long time, including a 2-point Dixon approach, a T2 prep, and in this case a crossbeam diaphragmatic navigator, one very large field of view, and a high resolution of 1 millimeter isotropic in this case. The sampling and the acceleration was performed using compressed sensing on a Poisson disk sampling pattern. And one feature that was included is to be able to reduce the motion during the acquisition window by reordering the case space in a center-out fashion. In this study, we compared two MR navigator settings. One that I called normal is an acceptance window of 3 plus minus 3 millimeters, and a fast version with plus minus 6 millimeters. So the first part of the study consisted of acquiring 22 volunteers and 9 patients. You can see that the ages match more or less. This wasn't on purpose, but in this case, obviously it's helpful. And over 90% of these patients and volunteers were scanned with both the normal and the fast protocol. All the images were then rated by 3 experts, excluding myself, on a 5-point scale you can see here. So to give you an overview, what was rated, first of all, the overall image quality was rated, then the myocardium was rated, the aortic root was rated. Although this isn't a scan specific for coronary arteries, we also decided to rate also the coronary arteries, the distal, the proximal parts. The supraaortic arteries were rated, the truncus and the AMS were rated, the renal arteries were rated, the pulmonary arteries, the pulmonary veins, and finally also the inferior and superior vena cava. As a second step, 15 patients were scanned with a fast protocol preceding a clinically indicated contrast-enhanced first bolus MRA in a single breath hold. There again, only the overall image quality was rated by two experts, and additionally quantitative measurements of the inner diameter of the aorta at 7 levels along the aorta were measured on the fast and on the contrast-enhanced MRA. First of all measurements were successfully performed, and as expected, the scan time of the fast protocol was reduced significantly to under 5 minutes. This is a very crowded plot, but you can see that there was in the mean no significant difference between image quality ratings between the normal and the fast in all of the locations I showed you previously. Here's one example of a normal versus fast protocol acquired on a 3 Tesla. So at a first glance, I suspect you can't see much difference here. Similarly, here's an example of a 1.5 Tesla acquisition. Again, here the structures are well depicted, and the image quality was rated similarly. The second part, again, image quality was not significantly different between the fast and the contrast enhanced MRay, although 11 aortic diameters in 3 patients were not measurable on the contrast enhanced MRay because of failed timing or a breath hold that wasn't acceptable. The Bland-Altman analysis showed a strong agreement between the ratings, the measurements of the aortic diameters between the fast and the contrast enhanced MRay. Here's one interesting example where you can see the native MRay gives a slightly different contrast for this thrombotic deposits in the descending aorta here. Obviously, for the contrast enhanced, this means that the contrast wasn't there yet. Who knows if it would arrive there? Obviously, it's very dark there. And the native MRay, which is a flow-independent acquisition, shows a T2 weighting. Another example of a contrast-enhanced MRay that more or less failed, where you can see that the native MRay in this case in under 5 minutes showed a nice depiction of this interesting aorta here. Similarly here, this is an example where both of them looked good, and also here you can see that the native MRay in under 5 minutes showed the nice depiction of the aorta. Okay, as a conclusion, we showed that a large field of view MRay is clinically feasible in under 5 minutes in this clinical setting here. The big advantage also is that no planning is required. It's really a very easy workflow here. Breathing motion artifacts can be traded a bit for without sacrificing image quality, obviously making the scan faster in this case, which is important. Measurements were similar between contrast enhanced MRay. We saw some improved or different visualization of the non-CE tissue. As a clear limitation, we're still using this classical MR navigator, which shows saturation bands, as you saw, but also comes with an unpredictable scan time, so we're working on that to improve that. What I haven't touched on, but which could be an interesting approach, is also to look at the fat images and to see things that possibly you wouldn't see on a fat suppressed image. And another thing we want to look into in the future is how to use this MRay acquisition to possibly do some automatic segmentation and also some volume quantification of the heart. With that, thank you very much for your attention. I'm happy to take questions.
Thank you very much. Maybe a quick question from the audience. Okay, I have one question, or maybe two. The first question would be, did you look into possible differences between 1.5 Tesla and 3 Tesla? Is one scanner more preferable than the other? And the second question would be, are you planning also some phantom studies, maybe using a motion phantom to further quantify the effect of blurriness in the images?
Yeah, so to the first question, so the sequence is available on both field strengths. Obviously for 3T you get higher SNR. You need to adapt the echo times to be able to have a good Dixon unfolding, but this is all in the range of feasibility. So we do see that there is an SNR drop for 1.5, but in general the images are good. regarding the motion, I think it's very complicated to have a motion phantom that mimics this cardiac motion and respiratory motion at the same time. So we just said, okay, let's test it on volunteers directly, where it's easier.
Okay, moving on to the next profit abstract. This is Maria Voigt, I think maybe pronounced that correctly, hopefully. Ultra-fast contrast-enhanced peripheral MRA clinical evaluation of a planning-free protocol in lower extremity peripheral artery disease.
Good afternoon. Thank you for the introduction and the invitation to speak today. I'm going to talk about ultra-fast contrast-enhanced peripheral MRA and the clinical evaluation of a planning-free protocol in low extremity peripheral artery disease. I have no disclosures. So to begin with, a little background to peripheral artery disease. As you can see on the right side, a patient with a severe necrosis of the fourth and fifth toe, with an increasing number of patients today being diagnosed with diabetes, hypertension, hyperlipidemia. The prevalence of PAD has risen up to 14%, further increasing with age. Due to cardiovascular-related deaths, PAD has a significant morbidity and mortality. Symptomatic patients usually undergo ABI index assessment and Doppler examination, and if a vascular intervention is necessary, of course it's beneficial to obtain advanced imaging for treatment planning of the lower extremities. As my previous speakers mentioned, we have DSA, which is the gold standard in the assessment of stenosis, occlusion, and collateral flow. It's invasive and, of course, can be diagnostic and therapeutic at the same time. CTA is regarded as the quickest and most widespread imaging tool in patients with PAD. Of course, limitations are the lack of dynamic flow information and the impaired diagnostic efficacy due to calcifications in the smaller vessels in the lower legs, and of course, as well as DSA, the radiation. MRA is also a well-established tool in the assessment for PAD, and its diagnostic performance is comparable to CTA. But especially compared to CTA, its main drawback is the significantly long examination time, as we heard before. On the one hand, this prevents widespread use of MRA in PAD due to limited availability and high economic pressure. And on the other hand, it often leads to poor quality or even non-diagnostic images, as many patients with PADs, especially those with chronic limb ischemia, have a low compliance due to rest pain or other comorbidities. Image acquisition for planning purposes and the planning of MRA itself take a lot of time. So how about shortening the protocol by eliminating these components? And this is where our ultra-fast planning-free MRA protocol comes into play. In our retrospective study, 15 patients yielding a total of 259 vessel segments underwent a planning-free low extremity CE first pass MRA at 3 Tesla following a standard injection protocol. We analyzed examination time, venous overlay, timing, motion artifacts, and overall image quality, to name a few. In a per-segment analysis, the parameters I mentioned minus the examination time were evaluated by 2 independent readers using 3- and 4-point Likert scales, and compared to another collective of 15 patients who obtained regular MRA. The average examination time for both groups was analyzed and compared to each other. In 10 patients who obtained ultra-fast MRA, we performed DSA the following day for an interventional procedure. The stenosis in the 10 ultra-fast MRA patients who obtained DSA were assessed with a 4-point grading system and measures of diagnostic performance to detect significant stenosis higher than 50% were determined with DSA as the reference standard. Our considerations were, and this also was mentioned by my previous speakers, that M-Dixon sequence has already improved CE-MRA for the lower limbs very much because no subtraction is needed and because of the good CNR and SNR of the images. As you can see on the right side, current resolution of MRA already shows tiniest vessels and collaterals, and CE-MRA is directly related to the contrast agent dynamics, so there's no further reduction possible here. But what if we just covered the whole anatomy? Benefits would be the better visualization of collaterals and possible bypasses, which would avoid unnecessary treatment and would provide a better preparation for the interventionalist. and there would be no need to plan the stacks. Our approach for the scan was that we took advantage of advanced acceleration techniques, in this case using compressed sensing with an acceleration factor of 15 in 3 Tesla. In this case, the acceleration was used to thicken the 3D volumes to include every patient into the stacks, while at the same time keeping the same resolution. Think of it like a one-fits-all solution. Second thing was precise patient positioning. We placed the foot support always at the same position on the table when we light the patient into the scanner. We had a fixed center point during positioning of the patient and fixed off-centers of the MRA scan in relation to the center point. Key results. Motion artifacts were significantly reduced in the ultra-fast MRA, whereas timing at venous overlay showed no significant difference for both groups. The mean examination time was significantly lower in the ultra-fast MRA group with a mean time of 244 seconds compared versus 667 seconds in the regular MRA group. Image quality had no significant difference in both groups, as you can see on the right side. Ultra-fast MRA as well as standard MRA were rated between good and excellent quality. Ultra-fast MRA had a high sensitivity and specificity for detecting significant stenosis. On the right side, you can see a female patient with a chronic total occlusion of the superficial femoral artery, popliteal artery, as well as ATA and PTA. And you can see it's a nice presentation that ultra-fast MRA can indeed reach image qualities same as DSA. If you even take a closer look, you can see that the remaining fibular artery in the lower leg has an even better contrast than DSA, which is not always the case, but I like this example because it shows that in certain situations, MRA can even be superior to DSA. So in conclusion, ultra-fast contrast-enhanced planking-free MRA allows imaging of the run-off vessels in PAD patients in approximately 4 minutes, which is very short, while at the same time having a comparable image quality to the standard protocol with fewer motion artifacts and a high diagnostic performance in detecting relevant stenosis higher than 50%. The reduction in examination time of up to 63% may improve patient compliance and make it hopefully more attractive in the clinical practice by minimizing non-diagnostic MRA studies. As we all know, MRA is comparable to CTA when it comes to diagnostic performance, but regardless, it's not as widespread. So we hope that with us, that our study contributes to a better acceptance of MRA in clinicians as well as patients. Thank you for your attention.
And thank you for the talk. Any questions from the floor? I have a couple of questions.
Okay.
Just to clarify, this was an M. Dixon?
Yes.
Yes, okay. I'm a big fan of MRA for lower limbs, particularly for critical limb ischemia, but I'm very intolerant of venous overlay, and I would never run an MRA in peripherals without using a dynamic imaging of the lower limbs below the knee. But you didn't seem to have dynamic imaging here, and you had about maybe 20% venous overlay.
Yes.
Would you prefer to run a dynamic as well, or what was the limitation that you didn't do that?
Yeah, that indeed was a limitation that we didn't run a dynamic MRA, but it's a nice consideration for the future to include that into the protocol, yes.
Anything else? Okay, thank you very much for your talk. The next talk will be given by Oda Ryotaro and is titled Noise Reduction in Magnetic Resonance Fluid Dynamics of Intracranial Aneurysms Using 3D Deep Learning Models.
Thank you for introduction. I'm Ryotaro Oda from Nagoya University. Today, I will talk about difference of noise reduction in magnetic resonance fluid dynamics of intracranial aneurysm with the spatial 2D with time and spatial 3D without time 3D deep learning models. MRFD may include noise from 4D flow MRI, potentially reducing the accuracy of 3D vector field analysis results. We constructed 2 models trained using training data, one with spatial 2D data with time, and the other with spatial 3D data without time. Our objective was to reduce MRFD noise and compare the accuracy of the two models. The study targeted 35 IA patients who underwent 4D flow MRI and 3D TOF MRA at 2 affiliated facilities. 5 cases were used for model validation after training, while the rest were used for training data. Scan parameters are shown here. On the left side is our special 2D with time model. First, we create 20 time phases of one slice 32 by 32 matrix data with the 3 velocity components replaced by RGB as the teacher data. Next, 32 slices of data are created per case. This process was performed on all the teacher data. Special 3D wizard time model is shown on the right. It also uses 20 time phases. For the ground truth data, the 3D-dimensional velocity vector data obtained by CFD was converted to grid data with the same resolution as 4D flow MRI. For the input data, we used pseudo MRFD data to which noise was added to the ground truth. I will illustrate it on the next slide. The input data was created by adding Gaussian noise to the 3D vector obtained by CFD analysis in K-space. For the deep learning models, both models utilize the Win5RB structure for the noise reduction model. 3D vector fields, streamlines, and WSS were used for qualitative evaluation. The angular similarity index and magnitude similarity index of the 3D vector data, root mean square error were used for quantitative evaluation, with CFD as the reference. The accuracy of the models was verified using two types of test data. The test data targeted the CFD and MRFD analysis results of 5 cases of cerebral aneurysm patients. In the CFD test, data with noise added to CFD was used as input data, and the results output by the training model were used as predicted data. Accuracy validation was performed by comparing the input data and predicted data with CFD. The second test was an MRFD test. Actual MRFD was used as input data. The results output by the model were used as predicted data, and these were compared to examine the accuracy. This is the CFD test results of velocity field. You can see that the noise in the input data is reduced for both models. The spatial 2D with time model, which learn temporal information, is better able to reduce noise in the small vectors near the wall. As you can see, circled area. About the streamlines, compared to the input data, the continuity of the streamlines is improved in the prediction results of both models. Looking especially at the prediction results in diastole, the continuity within the aneurysm is clearly improved in the model that learn temporal information, as can be seen from the connected aneurysm streamlines. These graphs show the temporal change in angular similarity index and magnitude similarity index. The orange line shows the results for the spatial 2D with time model. Both models showed high ASI and MSI values, but the model that ran temporal information showed higher accuracy validation value. Also, both models showed the highest ASI and MSI value in history, and the difference between the model increased toward diastole. For WSS, spatial 2D with time model is closer to CFD than the spatial 3D without time model, and it shows greater change from input data. For the prediction results of the spatial 3D without time model, underestimation of WSS is easily seen because this model doesn't learn temporal information. Also, looking inside the aneurysm, the model that learns temporal information shows a distribution much closer to CFD, especially in diastole. This slide shows the temporal variation of RMSE for WSS. with CFD as a reference. Smaller RMSE indicates proximity to CFD values. Spatial 2D with time model in orange shows the lowest value across almost all phases. Furthermore, both models showed their highest value during the systolic phase. As the systolic phase approached, the difference between the models became more pronounced. This is the MRFD test results. Both models showed comparable noise reduction effects for vector fields. The model in the middle that ran temporal information to show better convergence of the vortex center in both systole and diastole, with better vector continuity and improved accuracy. Compared to MRFD, not much change is seen in WSS with the spatial 3D without time model, but relatively large changes are seen with the spatial 2D with time model in the middle. Based on the trends from the CFD validation results, this model is considered to have higher accuracy. Especially looking at the WSS distribution within the aneurysm in diastole, the change from MRFD is clear. The spatial 2D with time model was trained on data with the same slice arranged along the time axis. This allowed it to run the noise distribution in each cardiac cycle, such as high VNR in systole and low VNR in diastole. This likely enabled noise reduction fit for each cardiac phase. Also, it was able to recognize the relationship between location, velocity, and time. And by removing noise that affects WSS calculation, accuracy was improved. By developing a deep learning model with a Win5RB structure using 3D vector data from CFD with simulated MRFD noise as training data, we were able to reduce MRFD noise. Our results suggested that by having the deep learning model run temporal information, noise reduction fit for each phase was possible. Thank you.
Thank you very much for this nice presentation. Is there any question from the audience? I was just wondering, as far as I'm understanding, you assume a constant noise value over the field of view, but in reality, we never have this because we have coil sensitivity profiles, and if you do acceleration, then you have noise patterns. And do you expect that the network even performs better if you also simulate coil sensitivity profiles?
Thank you for your question. But it's difficult for me here. So I take this question and consider. Sorry.
Sorry, I am a coder, and we measure the noise on the 40 flow MR imaging phase image on the setting the ROI. And then we measure the SNR and noise, and we add the noise on the K-space data set. So is it okay?
Okay, thank you. We'll move to the next presentation. The next presentation being Yuhong Liu from Beijing on ferumoxetol enhanced MR venography of the lower extremity venous network for the evaluation of varicosity in patients with diabetes.
Hi everyone, I'm Liu Yuehong from Capital Medical University, and I'll talking about lower extremity venous mapping and the detection of varicose veins in patients with diabetes using ferumoxetol enhanced MR venography. I have nothing to declare. Lower extremity chronic venous disease are highly prevalent in Asia. Varicose veins are the most common manifestation of CVD. Diabetic patients with varicose veins experience an elevated risk of mixed artery venous ulcers, life-threatening infections, amputation, and death. Peripheral artery disease and chronic venous disease frequently coexist in patients with diabetes, and their clinical presentation overlap. Compression therapy effectively relieves varicose vein symptoms, but it's contraindicated in severe peripheral artery disease. Comprehensive evaluation and early detection of varicose veins in patients with diabetes is clinically crucial because they require timely treatment for varicose veins before the onset of severe peripheral artery disease to prevent mixed ulcers and select appropriate treatment strategies. Lower extremity veins are classified into 3 distinct networks. Venous blood flows from network 3 to network 2, then to network 1. Disruption of this order constitutes reflux, which is the main cause of varicose veins. So comprehensive evaluation of these networks is vital for diabetic patients. Well, ultrasound is the first-line examination in screening varicose veins, but comprehensively performing a bilateral low extremity venous ultrasound examination is time-consuming. CT venography complements this ultrasonography in depth and comprehensive assessment and pre-operative navigation. However, CT venography presents certain limitations, including heterogeneous venous enhancement, radiation risks, and nephrotoxic issues. Varmoxolid is a kind of ultra-small suprapragmatic iron oxide nanoparticles received approval from the FDA US for treating iron deficiency anemia. It serves as a potent blood flow contrast agent. The China FDA recently approved the clinical trials of domestic varmoxolid for MR diagnosis. In our study, we used the domestic varmoxolid. It's a kind of USPIO with blood half-life of approximately 25 hours and comparable reactivity to Variheme. The study purpose is to investigate the feasibility of using varmoxolid-enhanced MR venography for comprehensive lower extremity venous mapping and detection of varicose veins in patients with diabetes. In this IRB-approved study, 4 healthy volunteers and 11 patients with documented type 2 diabetes suspected with chronic venous disease underwent the steady-state varmoxolid-enhanced MR venography on 3D MR scanners. This is our scanning parameters, and 2 independent observers evaluated the image quality, signal intensity ratio, and the diameter of perforators and the luminal signal uniformity index to superficial venous networks. This slide shows the varmoxolid-enhanced MR venography derived venous networks in a healthy volunteer. In this picture, we can see the branches of great sapphirous venous indicated by this blue arrows. And in the network 2, we can see the great sapphirous veins and the perforating veins. And we come into the deep venous systems. We can see the femoral veins and the post and anterior tibia veins. And this is a VRF 3D networks. And this slide shows a varmoxolid-enhanced derived venous networks of a patient with varicose veins, and the lesions appears in the network 3. And we can also see the great sapphirous veins and the perforating veins in the left leg. And in network 1, we can see the beaded shapes, the deep veins, and the femoral veins, and the enlarged deep veins. And this is VR of this varmoxolid-enhanced venography. And we can see that the diameter of this perforating veins is over than 3.5 millimeters, which meets the diagnosis standard of perforating vein insufficiency. And we obtained high image quality. The 2 observers strongly agreed on image quality and SIR measurements. The average heterogeneity index of steady-state thermal-enhanced MR venography for deep venous and great sapphirous veins indicated high luminal signal uniformity, and we measured from the 3 levels. And let me introduce 2 important structures. The first one is a saprophemoral junction. The saprophemoral junction is the point where the superficial vein meets deep vein. Its incompetence has been considered the most important cause of chronic venous insufficiency. So it's important structure in stripping and bypass surgery. Thermally enhanced MR venography depicts the branches around the saprophemoral junction, and we can evaluate the adjacent arteries and the veins. Another important structure is the perforating veins. Perforating veins connect deep and superficial networks. Thermally enhanced MR venography shows the different groups of named perforating veins and different types of perforating veins, and the 2 observers had a good agreement on perforated diameters measurements. Next slide, we come to the next network 1. In network 1, we found lots of varicose dilated and enlarged and twisted deep veins in the calf muscles in the patient with diabetes. And we also found the morphology alteration of femoral veins, which indicates the veins had leaky valve. Within 1 scan time, the steady-state femoral enhanced venography also revealed the pelvic and abdominal veins that were challenging to visualize using the ultrasound, enhancing anatomic insights and detecting anatomic variations, including dual IVC and femoral veins duplications. We'll all now know that dual IVC and femoral vein duplication is associated with increased deep venous thrombosis risk, but is often missed by the ultrasound. The femoral enhanced MR venography derived extremity venous mapping rapidly provides a comprehensive visualization of the entire lower limb venous networks and abdominal pelvic veins with 10 minutes without concerns iodine or gadolinium toxicity. But the steady-state vascular imaging was beneficial for simultaneous detailing a peripheral artery disease lesion without the calcification artifacts. However, it has been recognized that the proximity of the arteries and veins complicates below-knee artery stenosis interpretation. And MRI did not involve the functional information compared with ultrasound. So that's one of the limitations of the study. Dr. Young, my mentor, takes charge in the study investigating the clinical application of farmoxil, domestic farmoxil, as an MR contrast agent. We hope we can overcome the limitations in the future. I'd like to thank every single member of the team for their support and efforts, and thank you.
Thank you very much. Any questions from the floor? I have a couple of questions. You showed that you had a 1 millimeter isotropic voxel size, but you showed that the aortoiliac station was breath hold. Was that the same voxel size for the aortoiliac, the pelvis?
Yes.
Okay.
Yes. For the fourth station, we also acquired the 1 millimeter voxel size.
Okay. So when I'm doing these, I run 0.5 millimeter below the knee because the veins are all smaller, and I run 0.7 in the thighs. But you're looking for structures of 1 millimeter, but your voxel size is 1 millimeter. Would you comment? Do you think you should run a higher resolution, maybe?
Yes. So for the arteries and venous below the knees, we think if we get high resolution imaging, we can solve this problem. That's the arteriovenous contaminant. So for the below knee station, we think we can get a higher resolution.
Okay. My other question is about technique. When we compared our vein sizes on ultrasound to MR, we found that on MR that they were smaller because the patient is supine rather than standing up with ultrasound. Have you considered putting a tourniquet, a light tourniquet on the thigh to distend the veins a bit more to make the measurements similar to ultrasound?
Actually, we can. We think we can give it a try.
Okay, and one from Jeff.
Just a couple of quick questions. The domestic ferrimoxetol, is that approved for imaging, or is it like in the United States approved for iron supplementation?
In China, domestic ferrimoxetol has been approved for the clinical trials for MRI diagnosis, but it's not being approved for anemia treatment.
Okay, so the exact opposite of what we have. That's interesting.
Yes.
And I also noticed you say you infuse it over 6 minutes. I mean,
yes.
The FDA here says don't give it any faster than 15 minutes. Do you have any comment on the safety you've seen for this agent?
Yes, that's why we only perform the steady state ferrimoxetol enhanced venography. For the safety, we nowadays currently we perform the low dose ferrimoxetol enhanced MR angiography or ferrimoxetol enhanced MRI, and we perform the histosequence and the T2 star sequence to monitor the signal change of liver, and we also get some blood samples to test what kinds of change the body, the liver, and the hemoglobin, the kind of things. So we performed over 100 patients in China, and no adverse events.
So no immediate injection anaphylactoid?
Yes, no hyperintensive activities.
Fishbane type reactions?
Sorry, I didn't catch you.
Oh, there's a reaction associated with this called the Fishbane reaction, which gives you aches and that sort of thing.
Yes.
I imagine you would see some of that as well, but
yes.
I can talk to you later. Thank you.
Okay, I'll discuss later. Thank you.
Okay, we'll move on to our next talk, which is by Rui Tong from Shanghai, China. Fast, non-contrast renal MRA using inflow-based balanced SSFP with hybrid dual-centric case-space acquisition.
Hello everyone. My topic is fast non-contrast renal MRA using inflow-based BSSFP with hybrid dual-centric case-based acquisition. I'm from Neusoft Medical Systems, Shanghai, China. Inflow-based renal MRA is illustrated in this sequence diagram. In traditional acquisition, we acquired a single shot of SPE with all corresponding PE lines during each respiratory cycle using linear or centric case-based order. The acquisition efficiency is low due to short readout duration. Low acquisition efficiency leads to long scan time. Our purpose is to increase the readout duration while keeping decent contrast between the renal arteries and the background. Here is our strategy. We acquired 2 slice-phase encoding lines simultaneously during one respiratory cycle. The PE lines within different SPE lines were reorganized in a dual-centric order. Views with the same key Y but different key Z were captured at approximately the same time, thus maintaining consistent contrast between various slice encoding lines. We also used the pairing strategy of the view ordering to accommodate eddy current. We scanned routine and fast protocols both on 1.5T and 3T scanners. No discernible difference was observed between the different approaches on 3T. The background of fast renal arteries images was broader than routine approach on 1.5T due to a little longer effective inversion time. We can acquire more than 2 SPE lines during one respiratory cycle. We call the number of SPE lines simultaneously acquired reorder factor. Increasing the reorder factor can achieve greater scan time savings and get more vascular branches due to a little longer effective inversion time, but it may introduce some motion artifacts. In conclusion, our methods using hybrid dual-centric case-based acquisition provide us a significant reduction in scan time without compromising the image quality. Thank you for listening and welcome to stand by our posters.
Thank you very much. The next power pitch will be given by Gilles Roditi and is titled Portal Vein Flow Measurements in Patients to Evaluate for Mesenteric Insufficiency.
Thank you for that introduction. I'm presenting this on behalf of Pauline, who couldn't get here because of lack of funding from the UK. We've previously shown that it is possible to evaluate patients for chronic mesenteric insufficiency by only evaluating the output of the gut, which is the portal vein, which is a very large vessel that is easy to interrogate compared to trying to measure flow in the SMA, the celiac trunk, and the IMA, which are diseased. And the aim of this talk is just to introduce our initial clinical experience with this. We use a 1.5T system. We use 2D phase contrast, looking at the supraceliac abdominal aorta and the portal vein. We perform this with the patient fasted for at least 8 hours. We then take the patient off the magnet. We give them a meal challenge of 2 bottles of Ensure drink. And then after an hour, we put them back on and we repeat the measurements. At the time we put the abstract in, we had done 29 patients with an age range of 54 to 82 with varying degrees of steno-occlusive disease. 25 of the patients did not show any what we call significant flow increase. In our previous volunteer work, we showed that the flow increase should be at least 100% up to 200 odd percent. But in 25 of the 29 patients, there was no significant increase, less than 30% increase. And we've considered these patients to have true chronic mesenteric ischemia, mesenteric angina, and those that we've intervened upon with angioplasty or surgery have had good relief. One patient has been scanned post-intervention and shown an increase in flow from minus 23% to plus 37% and have no more symptoms. We have shown significant increases in flow, however, in 3 patients, and these 3 patients we considered not to have mesenteric insufficiency. One, in fact, went on to have a diagnosis of gallbladder disease and had a cholecystectomy. The others have been managed conservatively and had no further pain or weight loss. One patient has only had a modest increase in flow but after a meal challenge, but they did not have any pain, and we consider this patient to be in a grey zone. So we're not sure exactly what's wrong with this patient diagnostically, but so far they've been managed conservatively with no further weight loss or pain. So we're finding this a really useful investigation in our vascular multidisciplinary team meeting, where a lot of these patients are sent with a question of mesenteric angina, because this has been found incidentally when the patients had a CT scan, and it's sometimes unclear as to whether these patients really have mesenteric disease. So we're continuing to do this, and we're increasing our experience, and all the patients we intervene upon, we're now doing a post-intervention scan to gain more experience to find out how many patients fall into the grey zone versus the not mesenteric ischemia versus the ones that respond, so that ones that do respond, we have a baseline that we can then measure any further deterioration from if they get recurrent symptoms. Thank you.
Thank you very much. The next talk is by Val Li and is about dynamic enhancement pattern and renal angiography of second generation 3 nanometer sized iron-based MRT1 contrast agent named extremely small iron oxide nano.
Thank you for a nice introduction. I'm Val Li from Seoul National University Hospital. This time I'll be talking about the new contrast material made from the iron particles. Okay. Okay, so we used gadolinium, but gadolinium never been in our body in human history. But iron oxide particle is an inert and intrinsic blood compound, so we always have in our body. So is a sustained supply and cost effectiveness of new as a raw material. The small size of nanoparticle of iron act like a T1 agent. We are familiar with USPO, that's a very big size of a nanoparticle, maybe more than 10 nanometers. If it is small to 3 or 2 nanometers, it acts like gadolinium. The key is how can we make the uniform and small iron particle, and our team has a patent for this, and we can make very uniform and very small iron-sized nanoparticle. So the purpose of this study is to evaluate this extreme small iron oxide nanoparticle. I will call it as ASEAN, as in dynamic contrast material, dynamic MR angiography contrast material, and compare with the gadolinium. So we use 16 Leavitt, 12 assigned as ASEAN, and 4 is assigned the gadolinium. And as you can see, the graph from the aorta and the renal cortex and the liver, the gadolinium shows a steep signal intensity increase at 20 seconds and rapid decrease, but ASEAN shows a slightly slower signal intensity rise and then persistent enhancement exhibiting plateau. This is an example of the feature. You can see aorta and kidney cortex very clearly, and IVC and portal veins in both of the gadolinium and the ASEAN MR angiography. So it's exactly what we know as a T1 contrast material. While the ASEAN stays in the blood vessel for long times, we can do this delayed enhanced high resolution imaging because we don't have a time limitation. So we also did some study on the coronary MR angiography with ASEAN, and this time we can show this high resolution rapid renal angiography with a high resolution. So as a conclusion, ASEAN offers comparable first-pass MR angiography to that of gadolinium, and better in delayed imaging and steady-state imaging due to longer blood half-life in the intravascular pool. Also, it's a slow signal intensity in the renal parenchyma makes smaller vascular structure easier to identify. So this is new contrast material. We already done some toxic test. It passed, and then it excreted eventually through the kidney, but very slowly. I have the poster as now the Hideki shows that. So I poster, so if you have question content to poster, I will discuss about that. Thank you very much.
Thank you. And the last, I think, of the power pitch presentations is Toshimasha Clark, Effects of Objective Resolution Metrics in Simulated Contrast-Enhanced MR of Hepatic Vasculature, dependent on gadolinium injection plateau duration and tail height. Jeff is moving to the microphone.
Toshi thought this was tomorrow.
Oh, I think it's today.
I apologize to everybody. I know something about this. This is like your nightmare trying to kind of go through this. This is an idea that kind of follows on work that we've looked at before, really trying to look at how long the bolus is with respect to the acquisition time of your MRA. And this was done with an elliptical centric order and presented at various places, and it's kind of a mathematical model. And it kind of took phantoms like this that are as perfect as they can be given the resolution of the MR machine on the top. And as the bolus peak is shortened, you can see what happens with that kind of blurring because you are not getting enough signal during your high orders of K-space. So that's what happens with a very peaked bolus. So we showed that, and this is from that paper before, kind of showing that same amount of blurring. It's not a dramatic amount of blurring, but it is real. So the idea was, and I'd asked Toshi to put in some pictures of like liver MR, which is now not done in an elliptical centric way. It's done in a linear partial phase encoding like you can see here. And we kind of built some similar type models trying to see, because one of the problems we have, say with liver MR, is you look at the arteries and they're very blurry in your arterial phase. And this is kind of the way the model worked. We could kind of just, take a vascular and a non-vascular part and put different simulated contrast boluses through it. This just kind of goes through some of this. And what I'm going to ask you to do is to talk to Toshi at his poster tomorrow. And Toshi's going to hear something from me about this. But we looked at we call a plateau length of how long that peak lasts and then how low the tail is. And we developed some other models like this, kind of showing you how much extra blurring there is. And there can be quite an additional amount of blurring if that contrast bolus is peaked. And this is just kind of showing you some of the simulations for that, as far as how much error there is. And the conclusion is that there may be some clever ways to administer that contrast bolus that might help you with improving some of the vascular sharpness that we sometimes lose. And one of the things is to use a Z inner axis, which seems to help, but we're trying to figure out whether to maybe put in a little bit of extra contrast into the bolus so that that peak lasts a little bit longer. This is something kind of in evolution, and Toshi probably could have explained this a lot better than I can, but let's, it's a power pitch. Let him explain it at his poster tomorrow. So thank you.
Yeah, I guess this wraps up this session. Thank you very much for everyone who joined. Yeah, and see you later.
Okay. So after the coffee break, the next session will start on time, 4:30.